Thank you. Thank you for joining us today. This is the webinar we are putting together with Dr. Baliga. Our goal is to educate patients as well as the physician who manage diabetes mellitus. Diabetes mellitus is a chronic disease, and the chronic disease is a major problem for everybody, especially for U.S. healthcare. Out of $4 trillion, 90% or more money goes in managing diabetes mellitus. Medicare and other payers is trying to figure out what is the best way to reduce the cost while improving the care of the patient. And most research has now shown that bringing digital technology in managing this chronic disease is the best way to improve the care while reducing the cost. And we have seen that in our practice. It's been proven already, and we would like you to consider that in your practice. If you're a patient, you ask for it. If you're a physician, learn about it and try it in your practice. So this is the third seminar we're giving you. What we have done, then we are using digital health in managing diabetes mellitus in our practice, and we're going to share our knowledge with you. I am Subodh Agrawal. I'm a practicing cardiologist in Athens, Georgia. I did my medical school in Jaipur and did my residency and fellowship at Emory. I've been practicing in Athens for 25 years and really have great interest in accountable care organization where we improve the care of the patient by reducing the cost. I run the ACO here in Georgia, as well as really interested in new technology where we manage diabetes mellitus or other diseases like hypertension, congestive heart failure. We have developed a platform where we can receive data from the patient and give ownership of the data to the patient, where we can handle their problem remotely, effectively, and cost effectively. So with me is Dr. Baliga. Dr. Baliga is a practicing endocrinologist. He's a board certified endocrinologist. He practices Columbus, Plica, LaGrange in Athens. He has been the main power behind the management of diabetes mellitus and has created a great program which we're going to show you today. Dr. Baliga has been trained in endocrinology in 3 continents, in India, United States, as well as in England. He served as the director of diabetes program at Mount Sinai School of Medicine and passionate about his care of his patients. So he watches his patients very carefully. If you are his patient, if you have problems, you may get a call anytime during the midnight or late night. So he's well loved by physician and as well as his peers. And we will talk about how he's using the remote diabetes management in his practice. Why it is important to use technology in diabetes. Diabetes is basically a chronic, slowly progressing disease causing a lot of problems. It takes time to develop complication. So you have time to manage your sugar, manage your disease early, take control of yourself. And seeing patients every 3 months, 6 months is not the way to do it. You got to monitor your glucose on at least weekly basis to make sure that you do not develop glucose toxicity. And the best way to find that out to monitor your glucose on a daily basis, and then somebody watches you from distance and alert you if there's something goes on. Why is there a need for remote diabetes management? So just think about it. The diabetes is rampant. There are an increasing number of diabetic patients all around the world. There is shortage of endocrinologists, and this problem cannot wait for 2 months, 3 months, 6 months management. You got to be managed on a daily basis. Now, it was not possible before that you can see all these patients on a daily basis, but technology has made it possible that you will be able to see thousands of your patients every day using new technology. And we're going to discuss that today. So, Dr. Baliga, tell us about what has happened in management of diabetes. A lot of things has come up. We have pumps, we have continuous glucose monitoring, and a lot of things have changed. So, tell us, take it from here, and tell us our audience that how you use digital technology in your practice.
Thank you, Dr. Agarwal. You've been an inspiration for me. In fact, if you look back a few years ago, you were the first one to introduce me to these newer technologies like remote patient monitoring and chronic care management. And really appreciate all the hard work that you do to help my patients. As you know, I'm a very busy endocrinologist trying to take care of at least 4 offices, and I've got thousands of patients with diabetes. And as you can see, we are down here in the trenches fighting for our patients. And there are not enough endocrinologists, right? So, but the number of patients with diabetes keeps on going up. And the number of patients that we see in a particular day is not enough to cover all my patient base. So that's why we need technology so that we can keep all our patients in one group and try to do something called a population health management. And to do that, we need tools like remote patient monitoring. And I'm really glad that you came and met with me and showed me how the program works. And ever since, it has been a very useful program for me and for my patients. For example, using this technology, so we can get our patients glycemic results wherever they are. They could be in rural America, they could be in England, they could be in India, but we can get real-time alert about the blood sugars. I'm more worried about hypoglycemia rather than hyperglycemia. Of course, both are important because hypoglycemia can kill, right? The older way of managing patients when they come to the office once in 3 months, then download whatever glucometer they have. And as you can see, sometimes they bring the meter, sometimes they don't, sometimes they do the finger stings, sometimes they don't do. So it's a very frustrating experience. So now with these remote patient monitoring devices, we can get actual real-time data from our patients so that the sooner we get the data, then the sooner we can intervene. That means the patients are going to recover very fast. So that we want to tell our patients to use these meters and connect with us so that they can be kept safe. And not only that, let's say somebody gets a hypoglycemic episode, and we get a notification, and immediately we call the patient and take care of the problem right there and then. Otherwise, in the old days, they will go into hypoglycemia, they become unconscious, they will have seizures, then they have to call 911. So the whole idea is to prevent all that drama and keep the patient safe, take care of them at the earliest possible time, and prevent them from going to the ER or the hospital. And also, this program will help our patients to understand what kind of health goals we are setting them up for. Okay, we can talk to them about their diet, we can supervise them. Are they doing the proper things with their diet and exercise program, and all the different health care goals that we can put up for them. And more importantly, now we are talking about proactive care, right? The older way of managing patients was the reactive care. For example, a patient goes to the ER with a hypoglycemic episode. Then the next day we get a notification. Then we try to manage the patient. But now we are talking about, um, instead of the reactive, now we are talking about the proactive care because you prevent complications from happening in the first place. So that's where the money is. So by doing so, we can actually provide a much better quality of care. And the patients are happier, their satisfaction is much better. And they know that, because diabetes is such a bad disease, it causes real damage to our patients. And most of them, they are afraid. But now they know that in their difficult diabetes journey, they are not on their own. So we are here to support these patients. So when we talk about monitoring the glucose readings, the old way of doing it is just doing a finger stick, right? Um, so with this, our program gives our patients a glucometer with the Bluetooth capacity, so that whenever they do the finger stick, the readings come automatically to us, to our call center. Then we have continuous glucose monitoring system. We are trying to incorporate more and more CGMs in our app, so that we can get real-time data all the time. And this is one of the most useful things we are trying to do, so that our patients can get much better care. So as long as that glucose monitoring machine or a CGM device, if they have API, then they can connect to digital monitoring applications such as our Health Well Safe, using either a Bluetooth or cellular signals. So patients don't have to do much. All they have to do is use the meters that we give it to them. Then we get all the readings here. So we prefer CGM if people can afford it, because that has much more value. And we are going to talk about it in the next few slides. So how does the CGM work as opposed to a finger stick glucose reading? When our patients to do the finger stick glucose reading, we are actually looking at the capillary blood sugar. But when we look at the CGM, it's actually looking at the glucose in the interstitial fluid. For example, this is a schematic presentation of a CGM. This is the transmitter on the top, and there is a needle here. And that needle is a platinum tape, which is coated with the glucose oxidase. And whenever glucose molecules come and attach, there is a reaction called glucose reduction. And that converts into real data, which goes to the transmitter, which converts the data into milligrams per deciliter and transmits to the app. So there is always a question about how accurate these continuous glucose monitoring system. Several times patients tell us, Doc, the number that I see on my phone app is different when I do my own finger stick. So there's a reason for that. Remember, we talked about when we do the finger stick glucose, it measures glucose from the capillaries. But when we do the CGM, there's actually interstitial fluid glucose, and there is usually a lag of about 5 to 10 minutes. So that's why, in a steady state, when the blood sugar is reasonably stable, then both the readings are almost close to each other. Still, there is some difference. But if the blood sugar rises rapidly, right, then what happens is your CGM system, such as Libre readings, that will actually show lower reading, because it takes time to catch up to that real high blood sugar. The same thing, when the blood sugar rapidly drops, the CGM may show a higher blood glucose reading compared to the actual blood glucose reading. So that's the reason, if patients are unsure what's happening, if they think that there's something not right with the CGM reading, we recommend that patients should do a finger stick glucose and go with that reading and go by the symptoms. So there is something called a AGP report, is ambulatory glucose profile. So this is the most important thing. When we download a CGM device, the first page, it gives us that AGP report. So this is very important one, because this is the one which will tell us the time in range. So this is the new concept in diabetes, where instead of just looking at the hemoglobin A1C, now we look at a percentage of the time they are within that range of 70 at the lower end and 180 at the upper end. And we want to see about 70 plus readings, 70% plus readings in that range. And we don't want too many low blood sugars, what we call as time below range. And also, it tells us the pattern, how the blood sugars are behaving throughout the day and night. What's happening at nighttime? Does the patient have night eating pattern? Does the patient have a very low blood sugar around 2 or 3 o'clock, what we call as a Sumogi effect? Does the patient have a dawn phenomenon, uh, like most type 2 diabetes patients have? And what happens when they eat a particular meal? And out of the 3 meals, breakfast, lunch, and dinner, which is the problematic meal? So just by looking at this AGP report, we can assess what's happening in the last 2 weeks within few seconds, if not minutes. And we can also look at the highest and lowest. We can look at the variability. Then we can compare the current AGP report to that of the previous visit report. Then we can see, is the patient doing better or worse? This is a schematic representation. For example, here in the left upper panel, you see what we call as a Libre Pro reading. So this patient was not on a continuous glucose monitoring system. And initially, when the patient came, a Libre Pro was placed for about 14 days. And when you download it, this is what showed, right? So as you can see, the sugars are not under very good control. 33% of the time high, 3.2% very high. Time in target only 55%. Average the GMI is called glucose monitoring index was uh, 7.7%. So that means this patient is not under control, right? So we put this patient on a CGM such as Libre, and same patient after 2 months see the difference. Now time in target has gone up to 88%. Only 9% of the time blood sugars are high. Then the morning blood sugar, look at that. The patient is getting up in the morning around 80 to 120. See, those are the goals. In the morning, 80 to 120 while waking up. Postprandial, 2 hours after eating, not more than 180. Compared to the old way of doing the finger stick, the dots in the green, they're like finger sticks. And in the old days, we missed all these glycemic excursions. Like, what happened, how high the patient went after lunch or a dinner. And what happened, a lot of our patients have a night eating habit. So after snacks, see how high the blood sugar goes. So old way of doing just finger sticks 2-3 times a day didn't help us much. It did reasonably well in the old days, but now we have better interventions such as a continuous glucose monitoring systems. Now, this is one of the most important aspects of managing diabetes now, right? So the lower end is 70, upper end is 180. And if we can get our patients to goal, that is time in range of more than 70%, then half the job is done. The next thing you'll see is time below range. So in the red, I'm afraid of hypoglycemia. I don't want my patients to be having so many hypoglycemic episodes. According to the ADA, the allowed time below range is not more than 3 to 4%. Um, if it if it's given to me, I don't want any hypoglycemic episodes in my patients. Again, it's not going to be possible, but we can minimize it. So then time above range should not be more than 23%, and very high range should not be more than 5%. So that's the beauty of downloading a continuous glucose monitoring system and look at the AGP report in one instant just by looking at it. It will tell us how our patients are doing. Are they doing good? Are they doing bad? Are there any hypoglycemic episodes? If they're having hypos, what time of the day they are having hypos. So it gives a lot of information. Now, I use Health Well Safe as a remote patient monitoring tool for my patients. And one of the advantages is when I come into the office in the morning, I open my computer and I launch this app. And what I see is some of my patients, they need intervention immediately. So when you see that red triangle on the left, that means these patients need immediate attention. So what we typically do is either I call the patient myself or my nurse practitioner calls the patient. Then we do a visit right then and there, and we take care of the patient. So this patient has a continuous glucose monitoring system. So as you can see, if you look at the time in range, the patient is doing very well, right? Um, and there's a little bit of redness there. There's some hypoglycemic episodes. You see it around possibly just before dinner. But there is a spike between 3 and 5 o'clock in the morning. So this guy, he used to wake up in the morning and eat snacks. So this tells us our night eating pattern. But overall, this person is doing very good with the average blood sugar of 145. And then on the right side, it will tell us, what are the goals that we have set up for this patient. Then we talk to them about his medications. We talk to him about his diet. Um, this is the current therapy for the patient, right? As you can see, this patient is on Humalog and Synjardy tablet, which is a combination of empagliflozin and metformin, and long-acting insulin Levemir. So if I want to make any changes, I can make these changes in the app itself. And typically what happens is we'll be talking to the patient on the video call, at the same time looking at all this data on the side. Then we can have a meaningful dialogue with our patient. And patients will be very happy because when we talk to them, we have all the data on our fingertips right in front of them. And right then and there, we can talk to them and see. I can ask him to explain why the blood sugar jumped around the 3 to 5 o'clock. Then we can try to see what time of the day they're likely to experience hypoglycemia. Sometimes you may not be able to see the actual hypoglycemic episode, but there is something called relative hypoglycemia where the blood sugar drops suddenly and the patients feel hypoglycemia. And that's also not good, right? So then we know that the patient is getting too much insulin. So by talking to the patient, looking at the data, looking at the CGM, we can make a real-time adjustment and change the therapy. The next page, actually, you see all these options that you have. Let's say you want to use an additional therapy for this patient. So it gives you all the different classes of diabetes medication. Then you have to decide which is suitable for your patient. For example, one of the most used medication in my practice is a GLP-1 analog, especially Ozempic. I love to use it because it works very well, helps with the better glycemic control, weight loss, uh, protection against heart attack and strokes. So that's one of the main tools that we use. So we decided to add Ozempic. And we explain to the patient, let's go ahead and start you on Ozempic. We will call in the prescription. You start with 0.25 milligram once a week. If you need any help, please come to our office. We can show it to you. We talk about all the possible side effects and the hypoglycemia protocol, all those things. So at the same time, the system is so beautiful, we can create a note of this encounter and how beautiful it is, right? So, as clinicians, we are always running around doing so many things. And if you do a telemedicine visit, and if you can do the note at the same time within no time at all, that will save you a lot of time. Because for us, even few minutes are much more valuable because there are patients waiting, right? So this is a system, what I call is a complete system where you have a patient in front of you, you have all the data at your fingertips, and you have ability to change the medication right there in front of the patient and send the prescription to the pharmacy. At the same time, do a nice electronic medical record. Now you have a complete encounter. And in case there is an auditing, all the data is there with the timestamp. So this is how the note looks in Dr. Agrawal's office in his electronic medical record. So we can do telemedicine, we can do monthly CGM interpretation, we can do monthly RPM device code and monthly physician supervision code. So that's the thing, you provide a quality care in an ideal setting to the patient satisfaction. And now every minute that you spend is a billable moment, right? And we can generate money to the practice. Remember, all practices we suffer, right? Looks like we are doing a lot of money, but we keep on losing money. And recently, Medicare also announced that they are going to cut down by 8% our reimbursement. So then we need to be a little bit more careful because we have to keep our lights on. That means you work hard, but you better get paid for in a nice, legitimate fashion.
take care of themselves according to what needs to be done. Call the 911, go to the emergency room. Then suppose patient has hypoglycemia night, next day you find out what happened, and then we call escalation to your office, and you can call them when you are during the office hours. So I'm reassuring you, all of them, that this is a non-emergent management of diabetes, and when you are off, you're off. Nobody going to call you during that time. We will collect the data, and you will be informed on your working day. So the question is, Dr. Baliga, to you and to me, to strange things is why
Yeah.
not all endocrinologists taking this diabetes management, see, remote patient monitoring, remote diabetes monitoring, and taking advantage of new technology. It's a
Yes,
not
that's a very,
win-win situation for
yes.
for all patient, the pair as well as the physician. So the option of remote patient monitoring generated by the pair themselves, because this is a solution of managing the chronic diseases. So that will situation is a win-win situation. Now, what happened? A patient who had blood sugar at 200, 240, 250, he's not have much symptoms, and he see a physician, and physician order change in therapy, and normally they see after 3 months. So what happened between these two visits? I mean, at present time, a lot of practices not don't watch them, and the patient basically not having many much problem except glucose toxicity, which lead into complication, is not concerned too. But here, using this remote patient monitoring, we monitor patient every day. So if the problem is there, patient get treatment within short time, so they get a better treatment. The patient win. The patient get a better care because they've been monitored closely using remote patient monitoring. The physician win. The physician is able to see tons of patients remotely as well as in office. So this visit, the remote patient monitoring does not replace the office visit, but provide better care between the two office visits. Not only that, most pair, Medicare or commercial insurance, wants you to provide this service to their patient, and they're willing to they pay for it. So while you providing this service, every time, every minute, every second, you spend with the patient, in front of the patient, not in front of the patient, on the computer, watching their blood sugar, you get paid for it. So you win because you see more patients, you get better care, as well as increased revenue for you. The pair wins that the data is shown, the once you do remote patient monitoring, the emergency room visit as well hospitalization reduces, and patient get better. The best way to save money in healthcare is to keep the patient healthy and out of emergency room and hospital. So all pair love when their patients get remote patient monitoring, and they're paying for it, they're promoting for it. So because they save money. So it's a win-win situation for the whole healthcare, for patient, physician, as well as payer. So Dr. Baliga, tell us about how you help this patient who is live about 8,000 miles from you, and tell us the story that how important it was to follow this patient remotely, and how you use technology to get the best result within 4 weeks.
Yes. So this is an amazing story. Sometime in early July, Dr. Agarwal calls me saying that, "Oh, Suresh, I'm going to New York." I said, "Why are you going to New York?" He said, "Oh, my nephew, he's in New York. He's a doctor from India. He came for a wedding, and his sugars are running very high, in 400 to 500 range. So Subodh has such a big heart, so he just flies to New York with the Dexcom in his pocket, and then he calls me. Then I talk to the patient. Now, this this is his nephew, but he's a doctor, very hardworking, very smart doctor in India, and he works like so many hours, including Saturdays and Sundays. This is how doctors in India work. And I was like, um, flabbergasted when I saw these numbers. I said, "Oh man, he's sitting on a time bomb." And at one moment, he's looking after so many patients, but he's neglecting his own health. But he's a very smart dog, and we started talking uh, by video call. Then we took a detailed history, looked at his current medications. Then we put him on Dexcom G6. Then I could see his numbers remotely from here. Then I started making adjustment. We adjusted his insulin therapy. We added an SGLT2 receptor blocker. We added a long-acting GLP-1 analog. Um, and most importantly, we talk to him almost like a daily basis, monitoring his numbers and keep on adjusting his insulin dose. So if you look at this particular AGP report, which reads from July 17th to July 31st, his average blood sugar had already come down to 171. So within few days, remember, he started in a baseline of around 400. Then its GMI had already dropped to about 7.4%. So GMI is like a hemoglobin A1C in the last 2 weeks. I like that GMI number because when we talk about hemoglobin A1C, which reflects about 3 months of data, and most of them is a historical data, which I cannot use it for now. For me, it's very important to know what's happening in the last 2 weeks. That's where the CGM AJP report helps us a lot. So his GMI has already come down to 7.4%. Then if you look at that green, it says 62% of the blood sugars are within target range. When we started, he was hardly 30% in the target range, 35% high, 2% high. But most importantly, he didn't have too many low blood sugars. So that's very important for us because sometimes with our enthusiasm to help our patients to get better glycemic control, we give too much insulin at a short time and they can go into hypoglycemia. But having a sensor like Dexcom, and when you look at the app, you can look at the arrow mark. I always tell my patients, look at the arrow. If the arrow is pointing horizontal, that's a good sign. Your sugars are stable. If the arrow is going up, in the next 20 to 30 minutes, you're going to go up. But more importantly, if the arrow points down, that's the time you stop everything and take care of hypoglycemia. So before it happens. So as you can see, he did very well. This is before he left for India. Then he went to India. Then these are the medications. So I had to put him on Humalog. I think we went up to like 10 units with each meal. Then we started him on Ribelsus 3 milligram and started gradually increasing. We put him on long-acting insulin Tresiba, 20 units at nighttime. And he was on Jardiance 10 milligram in India, but we made it 25 milligram and we continued his metformin. So these are all his medications. Now he's fully covered. So that's what we do. We try to attack diabetes on all the angles because our patients need GLP-1 analogs, our patients need SGLT2 receptor blockers, we need insulin sensitizers, we need basal insulin at nighttime, and for a short term at least, we need short-acting insulin like Humalog. So this is when he was already in India, and I was so impressed by this young man. He took everything that we told him to the letter to his heart, and he did exactly what we told him to do. And he improved his diet. He started losing weight. He started drinking a lot of water, and kept on watching his Dexcom. And we used to watch it through the Dexcom has an app called Dexcom Follow. I could some of the nights I had to call him because his blood sugar was trending downwards. So, but look at it. Now his average blood sugar is 134. GMI is 6.5%. 97% of the blood sugars are within target range, and only 2% high, very little low. So this is an ideal story, right? A patient who is sitting on a time bomb. He could have had the worst outcome. He could have a heart attack. He could have had a stroke, right? He could have damaged his kidneys, gone blind. And imagine a highly placed person, a doctor in a society, and he could become an invalid with no fault of his, right? So, and this is where we bring the patient and the physician and the diabetes educators and the technology pioneered by, I call Dr. Agarwal my guru and a pioneer in all these remote patient technologies. So everything you have to bring it together. As they say, it takes a village to take care of these diabetes patients. So fortunately, this is an eye opener, and this is almost like a proof of concept. Like it's going to tell us that in this day and age where we don't have that many endocrinologists, how are we going to manage all these patients all across the globe? And this is the solution, right? Technology is going to save our patients. And we have amazing technologies, beautiful sensors, and we have got a beautiful this health wealth app save. We do the telemonitoring, and we constantly work with this app headed by Dr. Agarwal. We're trying to integrate all the sensors, like the now Dexcom is already integrated. We were talking about integrating Libre, then the Eversense. So any sensor can be connected to this app. And the idea is to get as much data as possible in one screen and talk to the patient at the same time and finish a visit within 5 to 10 minutes. Previous 62% time in range to 97% time in range now. This is a phenomenal by any standards.
So thank you, Dr. Baliga. What a fantastic explanation and example of using technology 8,000 miles away and getting an excellent result. Now, in this same patient, if you see in your office, you will see him in 3 months, which may not able to control blood sugar, but you did that in within 4 weeks with excellent result, almost perfect result. I wish we can get this kind of treatment almost for everybody else. So let me tell you what Health Well Safe can help you if you're a provider and want to go and bring technology in your practice. We made this thing so simple, and without any investment on your practice. We invest in your practice. We bring technology to you, knowledge, training, everything else. You provide the leadership and help your patient to get better care. We also provide cellular glucometer with test strip to all your patients with no additional cost. The reason we do it because that way the data from patient straightway come to our server and you can see them and you can follow them. We bring all diabetic patients who have been monitoring their glucose into one dashboard. So suppose you have like 2,000 patients or maybe 10,000 patients. So just imagine with technology, you're seeing all 10,000 patients who've been monitored by either finger stick, patient put data into the app, or by glucometer, cellular glucometer, if data comes straight to us, or by Dexcom, the data automatically come to us. So you have 10,000 patients, big practice. We monitor them every day. And then out of those 10,000 patients, we give you about 15 or 20 or 50 patients who need your attention. So just imagine that all 10,000 patients can be followed on monthly basis. Just the amount of revenue you can create. Or just you don't want to say 10,000, just monitor about 1,000 patients. Average endocrinologist who monitoring in diabetic patient, you probably have 500 to 1,000 patients. And if they bring technology in their practice, just imagine monthly follow-up. The Medicare allow you to bill for remote patient monitoring, bill for continuous glucose monitoring and their interpretation. And whenever you talk to the patient using our technology, that's called telemedicine, and you can bill. You can call 4 times, you can call 1 time, or you call nothing. So basically, and our system put all things together, create document, create billing, and we bill it for you. Now, the HealthWell Safe software identify all patients, they follow them all patients, and anybody will get hypo or hyper, and you decide where you want to see the patient, customize our system, and identify the patient when you want to see them. Not only that, we provide 24/7 dedicated support team for your practice. So if anything happens once your office is closed, we capture the data and we escalate to you, and you see that escalation when you are in office, not in off hours. So just imagine, if you don't do with us, do with somebody else. But this is the time for technology to bring to your office where you can provide better care, reduce the cost for chronic diseases. And that's what Medicare wants, that's what all the commercial insurance want. So the next thing we see that from physicians, or what about you, my EMR, I don't want to share with you because you can leak the information, or something happened to me. So, in order to answer that question, we bring to the to table that once you deal with us, we sign a business associate agreement which bind us. If we do wrong, we responsible. If you do wrong, you're responsible. Second thing, our platform is basically HIPAA compliant, and very carefully we monitor everything who goes in the system. We also encrypt everything from patient to the server, server to you, and you to the patient. So nothing can be leaked from our system. That's what we do. So security wise, if you share your data with us, we are responsible to keep the security and privacy of the data. If we mess up, we will be responsible, and we will very carefully invest heavily in it to make sure that all the information we have is preserved, encrypted, and safe. Dr. Baliga using this technology in practice successfully. He is providing better care. He's seeing more patients per day, per week, and he opening his schedule to he can see new patients. So you call him today, and Dr. Baliga will see him tomorrow or same day. Not many endocrinologists can do that. If you in our area, if you call endocrinology, they will give you appointment in 3 to 6 months. Can you believe that? Can you believe a diabetic patient with sugar of 240 or 50 or 300 will wait for 3 to 6 months to see a endocrinologist? Not with our system. If you use our system, we will have enough space in your schedule to be able to see new patients. So call us up, and then we will show you again demo with you. We basically our agreement is very simple. You use it as long as you want it, and you can cancel it anytime you want to. Bring technology. We invest in your practice. We invest in your practice. We give you glucometer and strip to your patient. So you're providing extra service to your patient. Not only that, the pair wants you to do it. So they can save money, they can keep the patient healthy. Thank you all for joining us today. Thank you, Dr. Baliga, for a great presentation. And we are open for questions. So the question comes out, how do your patient like using technology to better their health? If we give you example from 8,000 mile, they just love it. And there are patients who are not as comfortable with technology. But when they see the care, when they see, we call them up, oh, your sugar is 400. You need to come and see Dr. Baliga tomorrow to adjust your medication. Or if we do telemedicine and adjust your medication, they just love it. Say some pair do not cover this service. Also, other pair are keeping their eye regularly on the billing fraud and record. Just wondering if this is going to work in future. Beautiful. So let me tell you, um, most pair are paying for it. Some pair are not paying because they don't know how much money they are saving. And when you say the fraud, being billing fraud and record is possible, but our reports, everything we do with the patient is recorded. We text each other is recorded. Is recorded when we get the data is recorded. When you do telemedicine, recorded. And when we bill, we bill using our system. So everything we bill is backed up by record. So we basically help you when the audit comes in. We help you. We basically deal with the audit. That's why we bill. So it's possible billing fraud and records, but in our case, we basically do everything what Medicare wants us to do, and we keep the record. We help with the audit, and you will see the report, which will be our. I mean, basically, There's nobody else who has report like what we have. Every minute of the monitoring is recorded in the system. Like say 20 minutes need to spend with the patient. We don't bill until we show the record that we have spent 20 minutes. We don't bill a patient with pair if we don't have 16 days of recording in the patient. So we basically follow the law and produce the data before we bill. So not anonymous attending, thinking from physician point of view. Okay, that's totally fine. So physician had these doubts about, and there are a lot of problems out there, but you let us show you how you can defend, and we will defend for you. Everything we bill will be defendable. What do you think is important in preventing complication? Is the time in range or hemoglobin 1AC?
Yeah, so by traditionally we looked at a hemoglobin A1C, right? Because if you look at the UKPDS data, every 1% drop in hemoglobin A1C translated into a reduction in risk of microvascular complication by a stupendous 35 to 40%, right? So we still go by that because it's a very valid data which has been reproduced so many times. Now, the time in range is a new concept. Okay. Now, the time in range, the reason is if the idea is to get about more than 70% of the sugars within that target range, that should translate into almost like a hemoglobin A1C effect, what you call as a GMI, right? The GMI is almost as good as hemoglobin A1C, although there is some people think that it's not an accurate correlation between the two, but there is something. It's next to hemoglobin A1C, the best friend we have is a GMI. So to get a GMI closer to say around 7%, to do that we want our time in range to be about 70%. And again, we like to keep them in that range because then we can try to prevent time below range, right? Because we know that regardless of everything proven equal, but hypoglycemia can really damage our patients. So we all start with good intention because we want to prevent diabetic retinopathy, neuropathy, and nephropathy, right? And we can do amazing job using any diabetes medications. But nowadays we use a lot of GLP-1 analogs and SGLT2 receptor blockers to decrease the risk of what you call as macrovascular complications such as heart attack, strokes, um, and yes, so time in range is very important, but by still we go by hemoglobin A1C when you look at major clinical trials. But more and more for a clinical usefulness, that's a much better data point that we have at the moment.
So that a few more questions. One question is if the patient and doctor is not enrolled in the health system, how they get into the system. So I would say that we encourage the physician to stay with the physician and then introduce this technology to the physician, and they can enroll directly as a patient, and we can help them. Dr. Baliga can help them to guide them a treatment plan, and they can take that treatment plan to their physician. But if you live in Georgia or live in Alabama, Dr. Baliga can treat you as an endocrinologist. He got license in these two practice, and we can manage your glucose using remote diabetic management. But we really prefer that you stay with your doctor, and we help you with your doctor to stay on top of it. The other question is that if the patient have insurance which does not cover remote patient monitoring, then can they have subscription? Yes, they can. We charge very low. First 3 months is free, $20 per hour per month. This basically we believe that this is technology should be used in all patients. That's why the cost is very minimal. The other thing question is how much it costs to the patient and how much it costs to the physician. Can you believe that? The answer to this is not almost nothing. Now, if you're a patient and you're Medicare and you got no supplement, then 20% depend. You have to pay 20%, and that 20% can be usually covered by the co-insurance, by the second insurance, or if you're Medicare, you pay nothing. Then if you have no other insurance and you can show that you meet the poverty guideline, then that can be written off. So we believe that you should go for it. If you have commercial insurance, you 100% covered with that. So it doesn't cost much to the patient, except if you have only Medicare with no supplement, 20%. But you get glucometer, you get strip for life as long as you are in the program, and plus the care from your physician. But how much it costs to the physician? It basically, we have designed this that it costs no monetary cost. It does cost your time, it does cost your leadership and your guidance for the program, because your patient listen to you. But you create revenue for your practice by bring this technology to your practice. So you better care to your patient and plus revenue, and then you're able to see more patients. Oh, so next question is, what will be appropriate answer for patient when they want to know their AIC, A1C, and their blood sugar level is 58 fasting before a meal? So if Dr. Baliga, you want to take that question? The question is,
So I'm not exactly what is the question, but it looks like um, the person is asking about number of hypoglycemic episodes and if its effect on hemoglobin A1C.
yeah,
So yes, if fasting sugars are 58 and lower than that, uh, if you do a hemoglobin A1C at that time, it looks artificially much better, right? Because A1C reads average blood sugars. So that's the reason we don't want low hemoglobin A1C, especially in older people. Because if I give a lot of hypoglycemic episodes, A1C will look artificially better, right? We want a good A1C without any hypoglycemic episode. So this patient, if a person is waking up in the morning with a blood sugar of 58, that means he's taking too much insulin overnight. The first thing I will do is cut down the nighttime basal insulin by about 20%. Then I will see whether the patient has sulfonylureas on board, because older people with mild CKD, if they are on sulfonylureas, then they can have very low blood sugars. So first thing is to find out why it went low. If it is insulin, reduce the insulin dose. And if it is a sulfonylureas, cut down the dose by about 50%. So remember, we do not want low blood sugars in our patients. So we don't care about hemoglobin A1C that much. For example, a older person, say 70 plus, you don't want A1C around 6%. And the range is 7 to 8%, because we know that hypoglycemia is much more injurious to them than some artificial A1C number, right? So yes, be careful when you see patients with the low blood sugar, give some extra attention. These are the patients who need remote patient monitoring. These are the patients who need continuous glucose monitoring systems such as Dexcom and Libres and Eversense implantable sensor.
so the next question, are there currently any additional remote patient monitoring services on the horizon that will further benefit patients with hypertension and other cardiovascular disease? Yes. I think once we establish the diabetes management, the next tackle will do with the hypertension. The data is shown. The best way to treat hypertension is using remote patient monitoring. The monitor blood pressure using protocol, self-monitored by the patient. So we will introduce that soon. As soon as we have convinced our endocrinologist this is the way to do it, and then we go after cardiologists and nephrologists, and basically we are convinced this is the way to do it, and it's just a matter of time. And we will continue our effort to continue teach patient as well as the physician to use new technology in their practice, and create a win-win situation for all of us. Well, thank you, Dr. Baliga. You've been great. And thank you, our audience. And if you have any question, you can say info at healthwellsafe.com. We'd be happy to answer the question. And we will continue to do webinar again next month. And please come and join us. Thank you all.
Thank you, Subodh.
Thank you for joining our webinar. Be sure to follow us at Health Wealth Safe on all social media platforms so you can stay up to date with new healthcare technology. If you have any questions, please email us at info.healthwealthsafe.com. And remember, your health is your greatest wealth, and we want to help you keep it safe.